Thank you, sir. So my topic for today is, can a patient with autoimmune condition conceive? Standing amongst a lot of elite rheumatologists, I'm going to quickly brush over the various thoughts that a woman carry by herself when she plans her conception. So this happened when one of my patients with SLE stated, "Ma'am, already I have an autoimmune disorder and I feel my body is working against me in 100 ways. Is it safe for me to conceive? Can I conceive now? Is this the right time? Or do you think I should wait for some more time? Since I have the antibodies, am I going to be transmitting the same to the child? Or the medications that I have received till now, are they going to cause any impact on my child?" So in the coming up few slides, we will be talking about, does autoimmune disease contribute to infertility in the women who are affected by it? What is the impact of the therapy of autoimmune disease on infertility, as well as the impact that a woman receives during the course of a fertility therapy on the autoimmune disease? So infertility per se means it is a failure to achieve clinical pregnancy after 12 continuous months of unprotected intercourse. The term subfertility means delayed in achievement of this pregnancy, and which is more common in a person who is suffering from autoimmune diseases. So the leading common causes for autoimmune disease in our country, the first one is tubular factors, which is now promoted to be the first one as there is a rise of pelvic inflammatory disease, sexually transmitted infection. The second one is ovarian dysfunction. Over the course of the few slides, we will see how the autoimmune diseases and the medications, some of the medications do have an impact on the ovarian reserve. The next one, which contributes to close to 15 to 20%, will be the anatomical factors like septa, fibroid, endometriosis again, which is very closely linked with the autoimmune defects. Male factor infertility is again on the rise to close to 20 to 30% now. Unexplained infertility still stands for 10 to 15%. Premature ovarian failure, which is seen very much high over the past few years. The incidence in the WHO also stated a leap of close to 6% higher. Genetical disorders in 2 to 3%. Autoimmune again having between 2 to 3%. Chronic intake of certain medications as well as environmental factors stands with 1 to 2%. The infertility is a serious worldwide problem. It is on a rise. It is seen that it is close to 8 to 10% of the population all over the world is affected by infertility, which contributes to almost 60 to 80 million. Sadly, 50 to 20 million of them are from our country. So the reproductive autoimmune failure syndrome is first described by Chaitra et al. In women with endometriosis, infertility, and increase in the autoantibodies. The autoimmune mechanism as well as the increased production of multiple autoantibodies are involved in such infertility cases, mainly in a women who presented with primary ovarian failure, endometriosis, polycystic ovarian syndrome, and unexplained infertility, and women who had repeated implantation failures and IVF failures. So here what happens, the autoimmune issue and fertility is, autoimmunity is an immune reaction by itself, like we all know, due to the loss of tolerance. The pathological mechanism may be cellular or humoral. It can be involving the autoregulatory T leukocytes or the autoantibodies or the immune complexes which is produced in the autoimmune diseases. Here, multiple studies have now shown that the breach in the immune refuge gives the conceptus or the spermatozoa might lead to infertility or even recurrent pregnancy loss. It can either be it can be direct or indirect. Direct, when we talk about antibodies which is directed against the ovaries, anti-ovarian antibodies, anti-sperm antibodies, anti-endometrial antibodies, anti-zona pellucida antibodies, or antibodies against the FSH receptors. When we talk about direct effects, indirect effects, it could be immune-mediated endocrine abnormality, autoimmune thyroiditis, type 2 diabetes, type 1 diabetes, or vascular abnormalities and inflammatory and the inflammation could play a vital role in infertility. So they say a woman's reproductive system and her immune system are in a fascinating relationship that science is still to kind of explore more in. The fertility can be compromised when the immune response impacts either the fertilization or implantation or even the development of the embryo or the placenta. The reproductive immunology, just for the example, the most common thing and the one which is having a lot of popularity and multiple studies which has been done now is the natural killer cells. By itself works to protect the body against infection, diseases and even cancerous cells. Higher concentration of this is attributed to a implantation failure. Researchers have also demonstrated that the patients who have suffered repeated implantation failures are more likely due to autoantibodies and abnormal uterine NK cells. We estimate it by doing blood NK cells than those who enjoy a very successful IVF outcome as well. Autoimmune diseases not just affects women but also men are affected by it, more so in a person who's receiving certain therapies, and some of the medications does have an impact on spermatozoa and development of the sperm. So here what happens when we talk about the direct impact that is on the genital tract, the anti-sperm antibodies and the anti-FSH, when it leads to impairment of spermatogenesis, sperm motility, cervical mucosa penetration becomes impossible, as well as capacitation. Now in the oocytes, there is suppression by the anti-sperm antibodies, anti-zona pellucida antibodies, anti-FSH and HCG. On the oocyte development, the primordial follicles fail to develop into a mature follicle. Anovulation and luteal phase deficiency, wherein progesterone is very much on the lower side, more so in a person who is having polycystic ovarian syndrome. The higher levels of anti-sperm antibodies, anti-zona pellucida and FSH leads to a defective fertilization as well. Now when the anti-endothelial antibodies is on the higher concentration, that leads to a defective endometrial receptivity, decidual disorders and a higher inflammation in the endometrial tissue, leading to a failure for implantation. It also blocks the estrogen receptor, which leads to the failure of the attachment of the embryo into the endometrium. Again, progressively, the higher concentration of anti-sperm and anti-endothelium and even APLA leads to a defective trophoblastic invasion wherein the blast fails to implant. It blocks the estrogen receptor as well. And finally, as if it gets attached and then it's progressing, there is trophoblastic invasion. What we require next would be spiral artery modeling. Remodeling has to happen. Inflammation has to be kept at bay so the baby gets good sufficient blood flow. Thrombosis doesn't happen at the bed. So when the presence of these antibodies, it will affect that, leading to early onset IUGR, preeclampsia, eclampsia and even intrauterine fetal demise. One of the condition, the autoimmune regulatory gene, which is an inherited condition that occurs when there is a mutation in the AIRE gene, affects both the male and the female. In the male, it is predominantly, when we say in the prostate gland, it acts way from prostate to the testicles. There is reduced in the production of the spermatozoa, and once the abnormalities or motility problem, head effects are much higher in this population. When it comes to a female, it acts again starting from the anti-ovarian, which is going to reduce the amount of the primary amount of follicles which is remaining in the oocytes, in the ovaries, and increases the inflammatory T cells, leading to primary ovarian failure. The primary amount of ovarian follicles, which we usually do, we do something called antral follicular count to look at the amount of follicles which could be selected for this round of cycles, also is depleted. And there is once the oocytes are released, it has to travel through the fallopian tubes, and the motility also is affected here. And then also decreases the residual markers, and that blockage of these can lead to failure of implantation. Now coming to specifically with each autoimmune disease, not a lot, I know most of you all are waiting for the lunch. Very quickly, a few of the autoimmune conditions, the commoner ones and their impact of fertility. The commons, again, what we see a lot, and most of the women with SLE are very concerned when they start planning pregnancy, be it because of the previous history, the medications they've gone to, the ups and downs, the flares that they have already witnessed, which is a chronic inflammatory autoimmune condition, and this more so becomes important because it affects women in their reproductive age group. So in the peak age of their reproductive age, it's when it attacks them. Although currently most of the patients have a very good outcome with beautiful improvement because of the medications which are available today, Still, there is a higher risk of complication in pregnancy. It could be IUGR, it could be associated with preeclampsia, it could be intrauterine growth restriction, repeated miscarriages, higher rate of cesarean section because of preterm. Also, to very closely mention that some of the antibodies which they produce do cross over and affects the developing baby's cardia, which can lead to a defective which we continuously monitor in these women. These women are very well explained that they will be doing a continuous cardiac monitoring. So in case there is some transmission and there is effect of those antibodies on the fetal cardia. In an SLE woman, it is very clearly explained the pregnancy will be considered a high risk. And the reason for it is because of the condition as such can have a flare during the course of pregnancy. Some of the treatment that is administered in a patient with SLE, like cyclophosphamide, increases the risk of reduces the ovarian reserve as well as leads to primary ovarian failure. In those women, it is suggested that they go for an IVF, and even if required, donor egg also would be suggested for them. SLE flare is reported in a woman who is undergoing ovulation induction. So most of them will require ovulation induction, bleed, clomifene citrate or letrozole. We give it so we can enhance and increase the number of oocytes which can be produced. Studies have said that elevated amount of estrogen level is associated with the activity of the disease as well. So SLE per se, let's talk about infertility. When say preconception, it has to be monitored. The patients have to be explained about the consequences, the complications they will be facing down. We will definitely look into the activity of the SLE presently, a thorough history of the lupus and activity of the lupus nephritis. Associated antibodies has to be evaluated. And contraindication for pregnancy would be if she is in a active, if there is a flare of the activity of the disease is pretty high, there is congestive cardiac failure, pulmonary hypertension, and severe lupus flare less than 6 months ago, or end-stage renal disease, severe vasculopathies. So these are the conditions where on evaluation, risk to the maternal system then would be suggested to wait, complete your therapy, and once it comes to base, then we will start planning pregnancy. And in a woman who wants to preserve fertility, egg freezing would always be a good option for her. Antiphospholipid antibody syndrome, this mainly presents as repeated miscarriages, mainly in the first trimester, and mainly acts it inhibits the anticoagulant mechanism. It has direct cellular impact on both the endometrial cells, endothelial cells as well as the platelet. It has in these conditions there is hypofibrinolytic condition and also elevated complement factors. On the endothelial cells there is platelet and pro-inflammatory cells which adhesion is noted, and in the platelet it is the platelet adhesion and the aggregation which leads to a thrombus formation. Multiple sclerosis again is a condition which predominantly affects a woman in her reproductive age group and again becomes very important here. Multiple sclerosis is a neurological disease where antibodies are produced against the nerve sheath. This increases the risk of delaying pregnancy because it is in the peak again. The most common symptoms here the woman presents with is muscle weakness, mobility loss, sensory disturbance and paresthesia. And because of the muscle weakness, multiple women say they themselves want to postpone pregnancy. Genetical and environmental factors, low vitamin D levels, smoking and infections by some viruses have also been linked to the disease. There is much controversy about fertility as such with the women with multiple sclerosis. Some studies say that it does reduce the ovarian reserve in an active form of the disease. No increased risks of miscarriages, ectopics or cesarean section has been estimated. Pregnancy seems to decrease the number of disease recurrence and increases in the postpartum period. Assisted reproductive techniques like ovulation induction, IUI or IVF has the same outcome as that of the normal population. In the males, the possible causes of male subfertility in multiple sclerosis starts way from the hypogonadic state, that is hypogonadotropic hypogonadism, hypergonadotropic hypogonadism, or it can be a chronic inflammation or because of oxidative stress, or that can lead to the erectile dysfunction as well. Rheumatoid arthritis, again very common. in women, and it is, as we already have multiple times revised over this, it impairs fertility because of various reasons, not just because we start from the clinical symptoms. The pain itself reduces the rate, or the sexual desire is brought down because of the chronic pain that they experience. The inflammation which they are having again leads to a higher inflammation in the pelvis, leading to lower ovarian reserve. So here in RA as such, studies have now found a very close association with arthritis and PCOS, who have a very identical cytokine disorder. Both of them seem to elevate the tumor necrotic factor, interleukin 6 and 18. So both of them have been very closely associated in multiple studies. So the risk factors contributing to infertility in a female would be, leads to a premature ovarian insufficiency because of the medications. It is also very closely associated with endometriosis because of the high cytokine concentration in the pelvis. Polycystic ovarian syndrome, which I just mentioned about. And it also impairs the implantation as well as fertilization in a female. Also in males, RA has its own role to play. The medications, example, SARS, which is given to the patients who are having RA, do have a role to play in spermatogenesis and abnormal sperm production. Mortality as well as head defect is noted in few of the studies. Type 1 diabetes is more so, again, it is the clear association between type 1 diabetes and infertility is not known. But type 1 diabetes with a higher concentration of sugar definitely has a role both in men and female. In men, it is more of erectile dysfunction, and in the female, the complications because of chronic high blood sugar levels. Hashimoto's thyroiditis, this disease by itself is very different. Isolated elevated amount of thyroid antibodies can play a very vital role in implantation. Patients with Hashimoto's have decreased thyroid functions. They have a very fluctuant thyroid function. So when we start planning conception, we want the TSH range to be somewhere less than 2.5. Even though the normal is considered 4.5, we want it to be less than 2.5 to have a smooth fertilization, implantation and prolonging pregnancy henceforth. But a presence of these autoantibody lead to a very fluctuant levels of thyroid. This increases the risk of miscarriages, high level of primary infertility, and also the risk of having premature birth and fetal distress, and need of early delivery is required. Endometriosis and PCOS are the two conditions now which is very strongly, one of the theories which explains this. Way back when I was writing my paper, PCOS did not have inflammation as one of the etiology, but now yes, even in textbooks they quote inflammation has to be one of the etiology for polycystic ovarian syndrome. So endometriosis is a chronic gynecological disorder which affects close to 2 to 10% of the women. Again, even this is on the high now. This is because of, there is a large, this entire concept about how endometriosis happens is unclear. The endometrial tissue which is in the endometrial lining migrates. It can be retrograde migration from the fallopian tubes, found in the fallopian tubes or in the ovaries. By itself it causes infertility, causing the blockage in the tubes, making the tube more stiff, or developing an endometriotic or a chocolate cyst in the ovary. But association of this with endometriosis, with infertility and autoimmune is because of the high levels of cytokines that they have found. So if considering the last one, infertility, here the increase in the uterine NK cells is again attributed to a implantation defect. Oxidative stress and reduce in the vascular endothelial growth factor leads to a decreased quality of the embryo as well as the cytokines because of the elevation of the cytokines. The sperm motility is reduced because of the presence of interleukin 6 and tumor necrotic factor, which is present both in PCOS as well as endometriosis. So chronic inflammation overall can affect state from the hypothalamus to the pituitary to the thyroid to the adrenals to the ovaries and the testes, like we've discussed through overall. So can a woman with autoimmune disease conceive? Well, the answer is yes. If the patient is clearly monitored. I've put a very beautiful picture in concurrence, or when the rheumatologist and the obstetrician kind of work together, yes, it is possible. The disease has to be at its bay with no flares, the condition has to be well controlled, the medication which is not suitable in the course of pregnancy would be stopped before they are suggested for pregnancy. The knowledge and the risk factors has to be well explained to the patients before she even starts her conception. This becomes important because the medications, the method that she chooses also is important. If she opts to go for a natural conception, say for a good brief 6 to 12, unlike other women, we will not say 12 months straight, you please wait and try. In a person who's having any autoimmune condition, because of her subfertility, we would suggest you try for a brief 4 to 6 months, on failure of which she has to be evaluated for other gynecological problems along with the immunological problems. So we have a good brief time where we can control her disease, treat her and prep her 4 to 6 months down the lane. So the take home message here would be, in general, the systemic autoimmune disease do not seem to be associated with a higher rate of primary infertility. Autoimmune thyroid and adrenal disorders are likely to be associated with infertility due to the influence on the endocrine system. Recurrent pregnancy loss is more so seen in APLA and uncontrolled diabetes. Screening couples with infertility for APLA and treating them is still costly, and RCOG guidelines still doesn't approve of the same. Therapeutic regimens involving cytotoxic agents like cyclophosphamide and clonabutil is said to be associated with primary ovarian failure and infertility. The NSAIDs is said to be the culprit for a very short period of time, which causes reversible infertility, because NSAIDs will reduce the motility of the tube also, which is very required for the oocytes to migrate into the endometrial cavity. So evaluating a woman with autoimmune disease, her complement values, specific antibodies, inflammatory markers, other anatomical and hormonal status, all together will definitely have a good outcome. So infertility can be addressed based on her condition and present activity of the disease. Thank you so much.